Please welcome to the stage our speakers and Session Chair Matthew Taylor, NHS Confederation Chief Executive.
Hello everyone, welcome to this session. I'm Matthew Taylor. So we're talking about what does it really mean to embrace a continuous improvement culture. Now, the Confed is kind of obsessed with improvement. We're on a journey as an organisation to becoming ever more focused, becoming an improvement organisation, really. We see our future as a kind of improvement mutual, designed by, run by, delivered by our members. So this is absolutely central to us as an issue. The couple of questions I'm particularly interested in with our fantastic panel, who I'm going to introduce to you when I ask them to speak initially, is first of all, what do we mean by a continuous improvement culture, but also how do we foster such a culture in really challenging circumstances? Any of you who are NHS leaders or have spoken to NHS leaders will know that we are all wrestling with the issues that Amanda and I talked about yesterday, with the gap between capacity and demand, with money challenges that we have. So how do we talk about improvement in these challenging circumstances? And then secondly, this kind of question that I posed yesterday, you notice I'm quoting myself a lot, it's a habit I'm developing as old age sets in and growing pomposity. But how do we deal with this kind of what I call the split screen challenge, which is how do we address the immediate challenges we've got, and we'll have a new government soon which will have some very clear priorities, but at the same time do that in a way, and we haven't achieved this over the last 20 years really, do that in a way that aligns with a different vision. You know, perhaps the word of yesterday was reimagining. I think I've used it 6 times. I think Amanda used it 4 times in her speech. Reimagining the health service. So how do we do the stuff we need to do now, but do it in a way that's going to get us to that kind of different, more sustainable, continuously improving NHS? So those are the kind of issues that fascinate me. But look, one of the things about improvement is it is about a mindset, and it is about kind of energy, and it is about being willing to do things differently. So totally appropriately to that, and to your utter horror, we're going to start with a bit of audience participation. I know you're all thinking, oh God, if I knew this was going to happen, I would never have come to this event. You know, is it too late to sneak out from the back? No, I'm sorry. So what I'm going to ask you to do for the next 2 minutes is I want you to introduce yourself to the person sitting next to you. If you know the person sitting next to you really well, if they're your spouse or something, then go the other way. And I want you to, so I want you to listen, you have to listen very carefully, because the other person's going to introduce themselves to you, and I want you to ask them, what is the one thing that they most hope to get out of this session? Why are they here? Something, why are they here? What do they want to get out of it? What's the big issue for them? And then what I'm going to do, because you're all thinking, no, I don't have to do this, do I really? Well, you do, because I'm then just going to pick 3 people at random, and I'm going to ask you to introduce I'm going to ask you to introduce the person you've just met. So listen. You have to introduce the person you've just met, and you have to tell us why the person you've just met is here and what they hope to get out of the session. So you've got 2 minutes to get that information, because you may be picked on in front of the whole room. This is improvement in action, folks. Right, go.
You're right, Matthew. Oh, mine.
Right, okay. I've decided the 3 people I'm going to pick on. So the first person I'm going to pick on, because they deserve it, is the person who sat as far away from me as possible in the back row, you see. So I want you to pick the person who's sitting in the furthest left-hand corner at the back of the room, who thought they were safe. So tell us who you've just met and tell us why they're here.
Morning, everyone. I've just met Aaron. He's from Abbey Road. He's a GP. And why is he here? He's looking to understand more around what continuous improvement really means.
What a great reason to be here. Thank you very much. Okay, I'm secondly, just being completely arbitrary, I'm going to pick the lady in red. Not because I'm a Chris de Burgh fan, but just because I can see you, I'm afraid. That's what comes from wearing such a distinctive frock or whatever it is, blouse. Anyway, the lady in red is going to introduce us to the person that she's just met.
Thank you. I met Lindsay, who is an interim Chief People Officer and is here to shamelessly steal ideas, actually, to take back to her ranch.
Fantastic. And then third, I'm sorry to do this, it's not really fair, but we have a celebrity in the room, so I'm actually going to ask Sir Clive Woodward to tell us who he has... I think it's great that he's here, and he's going to be speaking very soon. You want to... Yeah, actually, it's a spontaneous round of applause. Come on, just go for it. Right. So, Clive, tell us who you've... here comes the mic. Tell us who you've just met and why they're here.
Good morning. I really wish I'd not come to this session now. I saw the words continuous improvement, and I'm talking about a winning culture later on, so I thought I'd just pinch a few ideas. But I'll introduce Hugh Brooke on my left here, charming young man. He's in charge of 5 GP practices, and he wants to just find out how he just getting better at what we need to do, and just trying to find out what's happening in the NHS on a more global scale than his 5 practices run in a Nantwich near Crewe in Cheshire. So pleasure to be here, and the real good session will be mine later on, so I hope everyone enjoys it. So.
Thank you,
Thank
Clive.
you very much.
So, Brooke, this has made your day, hasn't it? What's just happened, hasn't it? Yeah, very good. Okay, so we have one happy customer, whatever else happens. Right. Thank you all very much. And, you know, look, it was a bit of fun, but I think, you know, improvement has to have a bit of fun attached to it, doesn't it? It has to feel like it's something that gets your kind of blood racing a bit. So now let's turn to our fantastic speakers. And what they're going to do is they're going to give an answer, no more than 3 minutes, which is an answer to the question, which is what does it really mean to embrace a continuous improvement culture? I'm going to ask them a follow-up question, then we're going to have a bit of a chat, and then we're going to bring you in to the session. So Vinda Walker is National Director of Transformation. It says interim National Director of Transformation, but has enormous experience. I haven't got time to give you the CVs of these people. They're all, just assume they're all kind of demigods, really. They're all amazing people who've done fantastic stuff. And Vin's been particularly involved in NHS Impact, which is the national improvement programme developed by NHS England. So, Vin, what does it really mean to embrace a continuous improvement culture?
Yeah, thanks, Matthew. So firstly, for those who don't know me, I'm Vin. I am a paediatrician by background, used to be medical director at Birmingham Children's, and then at Great Ormond Street, and then in London. And I was privileged enough to lead some really fantastic quality improvement programs in each of those organisations, including not just working with improvement specialists and staff in the organisations, but actually some fantastic patients that were leading improvement in their organisations as well. So I've seen both firsthand and as a national leader and as a regional leader what it really feels like to embrace this. So I think I'd say a few things. First thing is we know that organisations that have really embraced quality improvement have better CQC ratings, much more likely to be rated outstanding, if that's how you measure quality. They're better patient experience, deliver better patient outcomes, better performance, better staff engagement, and more equal outcomes as well. So there is all the reasons that you've got there to really embed in your organisation. And that's why when Amanda first came into role, she felt very, very passionately that what she wanted to lead was a programme of work so that quality improvement becomes the go-to methodology for solving clinical, operational, quality problems, staffing challenges across the NHS, in every organisation and in every system, so cross systems as well. And I think that's a great vision and a really exciting vision to have it. Now, that is not a small challenge to do that. I think Chris Ham said we would be the largest health system in the world to have attempted to embed improvement at that scale across such a large population size. So really exciting, but really challenging as well. So if I start first by talking about models, because everyone gets fixated on, you know, what's the model of improvement that you're going to use? Are you going to use this? Are you going to use that? We did an evidence review in NHS England and basically said, and boiled down, there's about 5 key components of any quality improvement programme, so or culture. So number 1 is leadership behaviours. And leaders behave differently when they're leading organisations that have the systems and processes and the cultures and the capabilities in order to do that. And when I went to somewhere in the country which have really got that, for example, the chief exec every week on a regular time has a open session in the foyer of the hospital that they're running. People come along, there's 3 quick, sharp presentations, telling people what they're doing, a few questions, and it's in the foyer, so patients can come and listen and ask instead of, going into the local shops as well. It's amazing, it's energizing, I've seen that in several places. And it's shifting from a culture about saying, have you thought about doing this thing that I've thought about, to tell me about what you're doing. So it's a culture from moving from, big mouth to small mouth, big ears, big eyes. Second bit is having a shared vision, that's what you want to do, and a shared set of values. Third bit is creating time and space for staff to develop the capabilities that you need in order to be able to learn some skills for quality improvement at different levels. Second, having the capacity to do it. And then finally, and I think this is the bit that people often forget, is having the management systems in place to actually embed this in the way your organization works. And so that you've got it embedded in your governance processes, in your finance processes, in your operational processes as well. So that's what, for me, it really embraces and looks like. And when you go to organizations that have got this, you can touch it and you can feel it. And I remember going to one place and I stepped onto a ward and they had their 7 sources of waste because they were looking for waste across the trust. And then they had their SBC charts pinned to the wall. They could talk to you at great length. They were doing a ward round, and there was improvement discussion at the beginning and at the end, and you can actually see it and face it. And in fact, when I asked them, why are you doing what you're doing, they looked at me strangely as if to say, right, we've been doing this for 10 years. Why do you think this is new? This is just the way we do things around here. So that's, I think, how you can touch it and feel it. And I've seen some phenomenal examples in systems that I know Sam and others are going to talk about. So just go back then through history. It's worth remembering that we do have a bit of a history on this. The last really systematic attempt that we had to implement improvement across the whole of the English NHS was back in the early 2000s, in the old days of the Modernisation Agency. And in fact, David Fillingham, who led that, now chairs the National Improvement Board and is supporting us in NHS England to enable systems and providers, both primary and secondary care, to do that. So we learned from that. And if David were here, in fact, I've just spoken to him, he would say what they learned from the early 2000s was they took an approach where they really focused on staff who were actually delivering care to patients. But what they learned was that when those staff went back into organisations, they were dropping into an organisation that didn't have the culture. And so the approach we've taken with NHS, this large new national programme that we're doing, which we've called NHS Impact, Improving Patient Care Together, is to focus on boards and on leadership at board levels. And so we've got a whole range of activities that we've both started and ones that we will be planning over the course of the next year. So thanks to Sam, Emma and colleagues on this, we developed a self-assessment programme that's gone out to boards across the country to allow themselves to self-assess themselves against those key characteristics that I've discussed. And that's had a phenomenal effect, I think, firstly in enabling boards to baseline themselves, to understand where they need to, what sort of support they need in order to take things going further. I think it's really galvanised the chief exec and the chair community as well when we've talked about it. The second bit then is that we are taking the guides that we've got, the sort of improvement guides that those of us who are old enough will remember, and we're consolidating those into some really world-class, high-quality improvement guides that describe, if you've got an operational problem, these are the sorts of things that we know will make a difference. And sharing and spreading good practice is also a critical part of this, because you can take an improvement guide over here, but the real way in which you embed it in your organisation will vary in the particular circumstances that you're operating in. So you've also got to bring people together to share knowledge. And so over the course of the next few months, we'll be setting up communities of practice in order to allow senior leaders, operational leaders, clinical leaders, executive leaders of all professions to come together to discuss challenges and how they solve them. Out of that, there will be a very small number of things that are really difficult to solve. And that's where the role of an improvement collaborative, a large-scale national improvement collaborative, will come in. And as we iterate this, I think we'll learn by doing, and we'll be clearer where we need to put that intensive effort in order to actually discover and share and learn how to solve problems together. And then the final bit is training, because we are going to need to have programs to actually train, particularly if you think about the last 5 years. We've got a whole new generation of staff, of operational managers, of executive leaders that have come into post who weren't around in the 2000s and didn't experience the kind of development that my fellow panellists, Amanda, I, and others managed to get. So the final thing I'll just say about this, however, is that the other two things that are different to the early 2000s compared to now are, so number one, back then it was like a greenfield site. It was the first systematic attempt we'd had to introduce improvement methodologies into the NHS. We involved industry, who had a much longer history of doing it. People remember the sort of Toyota production system and that sort of thing, and we worked with those industries. Nowadays, it's a brownfield site, and actually the expertise to do this doesn't lie centrally with me in NHS England, my colleagues in NHS England. It lies out already in systems and in provider organisations that are delivering and creating this kind of world-class culture. And so in creating this, we very much want to create a kind of movement, a social movement that sits behind it, so that we're galvanizing, supporting and learning from each other, and not thinking there's going to be a sort of knight that's going to come from industry over the horizon that will solve all our problems for us. And so I feel genuinely energized by this. I think it's one of the most exciting things I've done in my career. And actually, if we're able to pull it off, despite the challenges, I think the NHS will be somewhere that we can genuinely look forward to working. Because as I've said, if you're a member of staff working in an organisation that has got this embedded, you've got power and you've got control about how you deliver care and how you support patients. And actually, that's a really great place to work and the kind of place you want to work. Now, that's not within its challenges. And the final thing I'll say that's different to 2000s is this, of course, that there's less money than there was in the early 2000s, but what we've got now that's different is we've got data. And the other part of my job as transformation director is leading the digital and data components. And actually, with data nowadays, we can produce real-time dashboards that will show you in real time what improvements that you're making, which will be very different to those of you who remember the old days. We had big spreadsheets and things stuck all over walls. And I think that is going to be quite an important enabler in all of this.
Vin, thank you. You've addressed the question I was going to ask you, so I'm going to move on straight away to Samantha Sam Allen, Chief Executive of our largest ICB, North East and North Cumbria. And Sam, what does it mean, particularly from a system perspective? Because generally speaking, Vin's talked about the history of improvement. The history of improvement in the NHS has overwhelmingly been with an organisational focus. You're looking at this from a system focus, where issues like collaboration are really important. So what does it mean to embrace a continuous improvement culture in the context of system working?
Yeah, thanks, Matthew. I mean, the first thing I want to say, it's an immense privilege to be the Chief Exec of the North East North Cumbria ICB. It's a beautiful part of the world to live and work, and the people who live in our system, who work in our system, are incredibly special. And I think, for me, I sort of almost want to turn it on its head slightly and think about what's our duty as public service leaders. We're, first of all, our leadership is about being in service to our community. So I think when the systems got going, and obviously our role as an integrated care board, our role as public service leaders is to really kind of create the environment and the conditions that enable us to have healthy systems and places. And in spite of how wonderful it is to live and work in the North East North Cumbria, and we've got some of the best health and care services, when you look at the metrics, the health of our population is really quite challenged. Our rates of respiratory illness are 42% greater than other areas in England. About a third of our registered population with general practice live in the most deprived areas, and 2/3 of our children live in poverty. So when I sort of think back to when I first became the Chief Executive, what are the things that were occupying my mind and dominating the majority of discussions? It was things like ambulance handovers, ED performance, but of course those are all symptoms of what's happening in our wider community. So your point, Matthew, around split screen thinking, if we just take a sort of a performance management orientated approach to fixing things, are we likely to improve things? Yes, probably. Are they likely to be sustainable in the long term? No, because what we haven't done is we haven't co-produced solutions, and also the people who have the ability to make the best changes are the people doing the work, who are on the receiving end of the work. So One of the things from a system perspective is, I mean, we're made up of multiple organisations, over 1,000 voluntary sector organisations, 11 large NHS trusts, 2 ambulance services. I could go on and on, 13 social care organisations. So the first thing to say is, systems, absolutely, from an NHS perspective, we need to support NHS impact, but we need to think beyond that. We have to think about our wider partners. So our approach needs to be inclusive and not exclusive. In a system, we can't be top down, so anything that we do has to be co-produced. So how do we do that? It takes time. So how in a system do we build the space where people working in the system, people receiving services in the system can come together? And our role as a system is to be able to convene people to come together. I think one of the best opportunities we've got in system is what I call peer-to-peer learning. In fact, our local government colleagues have been doing this for many years. They're very good at it. And we have got some examples of where we've done that through formal budding relationships, but peer-to-peer learning. Wherever you go in our system, there is excellence. There truly is excellence. But we've got variation, some of it warranted, a lot unwarranted. And how do we create an environment that focuses more on the strengths as opposed to just looking for problems all the time? If you just look for problems all the time, you see more problems. If you look at the strengths and possibilities, you see opportunity. So providing that space to do that, absolutely key. And I'd probably say the thing that underpins all of this is building trust and relationships. It's really fundamental. So looking back over the last 20 years, one of the things we've also had is a culture that's fostered highly competitive environments between organisations. Competition's not a bad thing, and I'm sure all of us that listen to Clive Woodward later will hear about actually that from a sporting context. Competition's healthy. We've set ourselves the mission in the North East North Cumbria of being the best at getting better. But there has to be a humility to that, and we need to engender a culture where people are generous, they share assets, and actually they're not purely competing, because if we are really in service to our communities, the public, using the taxpayers' pounds wisely, we'll be using the best of the best, looking at spread and scale. Matthew.
Thanks, Sam. So much to ask you, but I'm going to bring the other panel members in first, and then we'll get the conversation going. Sarah Sweeney, Director of Membership and Development at National Voices. One thing I hope you would have welcomed from yesterday is the emphasis that Amanda put in her speech on patients and on the fact that we have not always treated patients, listened to patients in the way that we should, and we need to get better at that. And even more eloquently in my speech, just checking you're listening, I talked about the need to think more holistically and continuously about what patients, not just because that's what patients prefer, but also the evidence is that it actually does reduce demand if you build that kind of care. So if you're a patient, hearing a phrase like continuous improvement culture just sounds like bureaucratic blah blah. How do we bring patients into this conversation?
It's a really good question, and yeah, absolutely, really welcome the comments yesterday from yourself and Amanda on really focusing on patients. Like, there's no one really arguing like patients shouldn't be involved, but in so many processes of change within health and care, it doesn't happen, or it doesn't happen in a meaningful way. For those of you who are new to National Voices, we're a coalition of over 200 health and care charities, and we come together to advocate for equitable and person-centred care. And like, obviously one of the key ways of doing that is by involving really diverse groups of people in a really activated way in shaping live decisions around health and care. And at National Voices, I oversee the research and the lived experience and the membership teams. And there's just so many different tools that we're using day in and day out, really to like live bring people's experiences and to really encourage people to share power in decision making, and really to try to like shift power to people in communities in being almost like democratic decisions about health and care. And I think that one part of this is a recognition that any individual as a leader will have their own lived experience. Like there's probably nobody in this room who hasn't experienced health and care in some way. And so we'll often be designing and making decisions and improvements based upon our own kind of mental model that's based upon the experience that we've had and how we might imagine other people experience it. But society is so diverse, and the way that we experience things, according to like demographics, where we are in the country, personality type, just the day that we attended our GP, whether that was just a good luck day or a bad luck day, is so different. So some of the tools that we use at National Voices really to help people with this. One of them, for example, is our Voices for Improvement programme, which we were able to start thanks to the folks at Health Foundation. And in that, for example, we've brought together a group of lived experience partners who all have their own lived experience of disability or caring, and who also come from mainly from communities that experience inequalities. And for those individuals, what we've done is we've really invested over a long period of time. And they're all individually able to reflect upon their own experiences of health and care, but also that kind of theoretical kind of power exchange that happens with co-production. And they're matched in coaching relationships with senior leaders in health and care, who are given that kind of time to reflect on their own practice and to kind of wrestle with the live issues. I mean, one of the biggest kind of challenges and barriers to co-production of improvement initiatives is just having the time and the resource to kind of sit there and sit with the difficult questions, not run straight into action mode, but really try to wrestle with those. That's one of the tools that we use. Another example that I have to hand is some work that we're doing at the moment with the Greater Manchester Cancer Alliance. They had found that some groups in Manchester who had the same symptoms, for example, of cancer, were less likely to come forward to primary care teams and get the support that they needed. And so we did a kind of engagement where we did like a wide survey across Manchester. And then we also did a piece of work focus groups with communities who were most affected. And some of the issues that come up aren't the things that you'd expect. So if you kind of sprung straight from the stage of saying, this is a problem and let me fix it, but never involved any people in communities, you could miss some of the biggest things that actually matter to people. Like one of the things that I found really interesting that came up pretty highly in the survey, like one of the practical things was around people just finding it hard to like get off work and go along to an appointment, especially for people who were living in areas where getting the bus to a hospital, for example, was a really long distance. They were only running not as regularly as they would need to for that not to kind of cut out half of your working day type thing. We're also involved, for example, with the work that NHS England and SCW are doing with Core 20+5 community connectors. And connectors is over 500 people from communities experiencing inequalities in England who are both kind of reaching out to communities with that, the messages from the health and care system, but also helping to kind of transform and fundamentally improve health and care and the way that it's being structured and delivered. And it's really, I think for me, some of the lessons are if you really trust that people and communities might have solutions to things, that you recognise that sometimes we just short circuit. You know, if we're trying to, for example, make gains in productivity, we can easily make decisions that kind of cut out perspectives of patients. So for example, one of our members was telling me not so long ago this kind of shift, for example, to diagnostic hubs around ophthalmology meant that all of a sudden, because you had a technician delivering scans, you could really improve the amount of scans that could happen in a day for people with visual impairment. And obviously that's a wonderful thing, but one of the things that was missing was that people actually who were having issues with their sight were going to appointments thinking they could talk to someone who'd be able to tell them more about what this meant for them in their lives. And they were getting the scan, but they were leaving without that certainty of knowing actually what does this mean for me? Is it going to affect what I'm able to do, whether I can see my friends and family, my work and everything else? So it's kind of, we can sometimes jump straight to solutions and not consider the mental health or the emotional impacts upon people. To quote my boss, Jacob, who's Chief Executive of National Voices, I've never heard of anyone who's involved patients or the public in decision-making in health and care and ended up with a worse decision. And there's so many different tools that we can use. So the words continuous improvement will probably never be the words that everyone in the British public understands, for example, or has come straight to mind. But yeah, I think whenever we really plug in different and diverse ways into that kind of power sharing with people and communities, it can be pretty magical.
Brilliant. Sarah, that's really powerful. Thank you. Last but not least, Amal Shah, who's National Clinical Director for Improvement and Consultant Forensic Psychiatrist and Chief Quality Officer at East London NHS Foundation Trust. Amal, you've got a lot of really practical experience. So answer the question, and it'd be great if you could share with us in answering the question, what does it mean to embrace a continuous improvement culture? Give us a kind of practical example of this.
Sure. So a culture in which we see continuous improvement is really one in which people feel like they can see challenges as opportunities. I think that's the first thing, is being able to bring a solution mindset, being able to have a growth mindset. When they see something that's difficult and a challenge, that they see that as an opportunity, and then they can see the improvement method as a way to work through it. Beyond that, people need to feel like they can contribute to solving the problem, that their lived and learned experience as clinicians or service users or in the local community is actually valued, and that there's a way for them to bring that into the solution. And then they need to feel like they have permission to act. And those are really the core components of culture. And culture is really how each of us behaves all the time and how we interact with each other. It's a relatively fragile thing, and it's made up continuously of our own behaviors. And to get to that point, really it's about belief in many ways. Improvement is both a mindset and a method. And the mindset is really about how we act, how we are, what we believe. And to really build belief in improvement, you have to recognize the value of utilizing people's experience and wisdom in solving problems. I mean, there's a fundamental question here about, do we think the problems are best solved at senior levels or at the point of care? You know, what is our current mindset about and mental model about how problems should be solved? And the only way really for people to believe that there is a different approach to this, which involves people and their own lived experience in solving and identifying and solving problems, is through being really proximal and close to the work. So for us to really create this culture, I think we need, particularly for leaders, the responsibility of seeing their role very differently. Many leaders have gone into senior roles through being expert problem solvers, and suddenly they're in a role now where they're not expected to problem solve anymore. They shouldn't be problem solving. Actually, our role now is problem framing and creating the climate in which others can solve problems. That's very different, and we need to sort of learn our way into that, unlearn some behaviors and learn some new ones to really think about what that means for us as leaders to create that climate. For those of us working in clinical teams or receiving care, we need to think about, do we have the skills we need to improve the system? Improvement is a discipline. It's a science. We need to learn and apply that. And for the last 15 years or so, I've been trying to learn and apply that in a range of different settings. As a forensic psychiatrist, growing up with George Clooney in ER and Callista Flockhart in Ally McBeal, I ended up in the field of forensic psychiatry. And for 10 years, I practiced that and learned at that. Not once was I exposed to improvement, or did I feel like I had an opportunity to contribute to improving the system. And that is the experience we need to change for people. That people build skills, they have the opportunity to contribute, and they have the support around them to really work through really complex challenges. But fundamentally, it's about belief. Where are these problems best identified and best solved? And do we genuinely think that those creative, innovative solutions are going to come from the people who are closest to where the challenges are experienced?
Great. Now, Vin acknowledged in his comments that when we first tried this in the early 2000s, we were in an environment where budgets were rising by 6 or 7% a year in the health service. We're talking now about improvement in a more challenging context. And I want to start with you with this question, but I'm going to ask all the panel to respond to it. I was talking to a really good primary care network a few weeks ago, who'd done some really interesting things which had changed practice, changed GP practice, improved access, and various other things. And I said to them, how did you start this process of change? And what I found been really interesting was that they said, we didn't even begin the process, the people who'd led the change, until we were able to prove to the GPs that it would improve their workload. Because we knew that at this time, to say to people, this will be more efficient, more productive, even, I'm afraid, to say this will be better for patients, you just get, well, look, if you want to be better for patients, you wouldn't be putting me in the position I'm in now. It's all very well about talking about efficiency, but they had to start by saying to the clinicians, this will make your life better. That was the only way to open up the conversation. So, Amar, in terms of what do you think, in this environment, with the pressure that people are on, how do you start the conversation about improvement? Perhaps posing this question to you first, particularly with clinicians.
Well, I think I go perhaps even one step further. Rather than trying to sell an idea to a clinician around what matters to them, maybe ask the question, first of all, what matters to you? Last Thursday was the Global What Matters to You Day. And I think that's a really powerful, open question, which should be at the heart of all improvement work. If we're not improving the things that really matter to people, and by people I'm talking beyond clinicians now, people who receive care, people who are in our local communities, if we're not really tapping into what people really care about and their intrinsic motivation to make the system better, to improve those outcomes, we're probably not going to be focused on the most important things. So I think we should be starting with that very simple, powerful question: what matters most to you? And then creating a consensus within the team of patients and staff together about their most important improvement opportunity, and then applying the science and the rigor of improvement to be able to work through that complex challenge together. And through doing that, we're tapping into what people really care about, that intrinsic motivation. But we're also building relationships and flattening hierarchies and learning how to work together in partnership and accumulating the wisdom that people have from different disciplines and different experiences to be able to solve problems.
Great. So, Sarah, a lot of patients day to day at the moment are not having the experiences that they want to have. We know that. We know it anecdotally, and we also know it from the survey evidence that shows that people's confidence in the health service is lower than it's been in the past. How, people in the room who want to engage patients, carers in this conversation, and they might feel a sense of trepidation because they might feel to even open up that conversation, people are going to go, well, you shouldn't be starting from here. That they're just going to be so full of disappointment about how they've been treated that it's quite hard to have that positive engagement. So how would you encourage people to start the conversation with patients' organisations?
It's a good question, because I think some of it is around, a wider investment in the infrastructure to make that possible within roles. I think a lot of people, it feels quite difficult because you're like, what do I actually do to get from where I am now to really engaging with a diverse group of patients? And some of that is, I think, for leaders really to create the investment in infrastructure around roles. I guess one of the other things I would say is, we talk to thousands of patients all the time at National Voices, and while there is obviously the lower levels of satisfaction in services, and it's very concerning, obviously, the levels of inequality as well in which people experience services. There is that broad support for the principles of the NHS, and people we witness every day give very freely and generously to try to understand how we can make services better. So I think some of the things I recommend are very practical things, like working through trusted intermediaries, for example, voluntary sector organisations who have trust and recognition within communities who haven't been well served by services. I think recognising that you can't expect people to come to you, that you have to go and meet communities and people where they're at. So it's not just a case of opening the door and putting a sign up. That's not going to attract the types of people who are already not well served by services and things, because the last thing you want to do with your free time, if you've just been treated very badly within the service, is to spend some more time in the same service. So it's looking at inroads into communities. And I think it is a long-term investment, and I think that some of the issue and challenges we've seen is that sometimes I think people expect to see immediate results of engagement, immediately meaning that people are instantly happier, but often the kind of narrative or the issue that communities have been experiencing are over very many years, and the amount of time it takes to build trust back with communities is over very many years. So sometimes you see a program going in for 1 year and then disappearing. So addressing the trust issues and then just disappearing back into the ether again, sort of thing. So something for individuals as professionals, it might feel like a one-off transaction where you just want to get input into this one decision. But for that person, that's their whole life story. It might be a really traumatizing event for them. So trying to think about what is it that the individual wants to get from this, and trying to look at, relational approaches as well. But I think that argument is underpinned by investment in the infrastructure and in communities. And I guess that's a reflection of the dignity that you give to people, the respect and the enthusiasm as well that you really want to hear from them.
Thanks, Sarah. We're recording elements of this conversation for one of the podcasts we're doing with Q Network around improvement, which you can access through the NHS Confed website. But we also do another podcast called Health on the Line. The last one we did was with South London and Maudsley Mental Health Trust, who'd worked with Citizens UK to undertake a fantastic process, South London Listens. And that was one of the big lessons there, which is that when you engage communities, they're not going to say what you want them to say initially. Yeah. You have to stay in the room and you have to work with them. And don't do it because you think people are going to go, oh, thanks a lot for talking to us. It's a deeper process than that, and it will take time. Which brings me, Sam, to you, because I was privileged to be involved in one of the first meetings you had around the way you've approached improvement, which is highly inclusive. And where I've seen the best examples of improvement, I'm a great fan of the Mid and South Essex stewardship model, it has this egalitarian feel to it. So tell me why that inclusive approach is so important to the way you approach improvement. And what's the challenge for you? Because you're the boss in making people feel that sense of ownership.
Well, yeah, but we've got 3.2 million people in our system, and I kind of think if we can get to a place where everybody's the boss of their own healthcare and their journey, that's where we want to get to. But I suppose just going back, in July 22, when we became an organisation, and with the Act, there was no how-to guide for how you did improvement across systems. We looked at the global evidence, and I remember, Matthew, I think you came to one of our urgent emergency care events, and first and foremost, it's about respecting everybody around the table and being inclusive of people who use services, patients, family friend carers, and all professions across health and social care, voluntary sector, independent sector. So we actually started by saying, how do we do this? We really think actually a focus on improvement and continuous improvement will be good for our system, but we didn't want to impose something top down. There was nothing that said this is how you do it, this is what good looks like. There were lots of examples elsewhere in the world. We looked at Yonkoping, we looked at Cincinnati. So we convened a space in September 22 where we had members right across the northeast North Cumbria. And one of the things that's become a sort of a key thing whenever we convene, we always start with the voice of lived experience. So I remember that event really well. We started listening to a story of somebody who's bereaved by suicide, and also somebody who'd had experience through the ambulance service and social care. And we asked the system, actually, we think we want to co-create improvement. What do we do? I think the visibility of leaders was really critical. This had to be seen as something leaders were going to sponsor, commit to, and not just pay lip service to, for it to be something that sat on the side. And out of that event, we've created something which has become known as Boost. You can look at it, boost.org.uk. We've now got a learning and improvement community of over 7,000 members. We've got multiple communities of practice. Our communities of practice are drawn from people working in health and care services, in our communities, a voluntary sector, and in fact, people from across the country and across the globe. And through those communities of practice, we're seeking to design improvements and solutions, but really foster and protect and create space for innovation and improvement, and networks and exchange networks to do that. So that's the sort of fundamental bedrock of which we're building our continuous improvement system on. There's 4 aspects to it: learning, growing, improving, and connecting. And I think more than anything, fostering the relationships, the trust, and the conditions. But it absolutely has to come with the science. So how do we give people the training on the improvement tools? From an integrated care board perspective, we didn't inherit, unlike a lot of our provider organisations, long history of improvement. So we're now embarking on our own improvement approaches and really using the assets. We were fortunate and delighted that the Health Foundation have been alongside us on this journey, that we've been able to tap into existing networks like Q Community. So you do not need to start from zero. There is a wealth of knowledge and information out there in our communities and organisations. And I think for we as leaders, and I suppose for your question of me, Matthew, and my role, it's about making the space where these connections can be made, but that they link into outcomes. And I think we really believe that healthy systems that have got this culture deliver better outcomes. So it's important work that we need to pay attention to.
Thanks, Vin. Thanks, Sam. Vin. I wasn't confusing you with Vin. I was just getting ahead of myself. So Vin, I'm a chief executive in the NHS, and I've had a phone call from NHSE, which has been basically, sort your budget out, sort your waiting lists out, sort your UEC target out, or else there's going to be trouble. And I'm kind of reeling from this. And then that nice Vin rings me up and says, "Hi, we're here to help." How, given that NHSE has to deal with some pretty tough stuff, and there's a lot of tough conversations right now. How do you ensure that people see you nationally as an enabler rather than an instructor when it comes to the improvement agenda?
Yeah, so I think the first thing that we've got, which we're incredibly privileged to have, is that Amanda really believes this. And so setting the tone from the very top of the organisation, the very top of the NHS, is really, really important. And secondly, I think we as NHS England are very committed to changing ourselves. We have come together now as a group of 3 organisations, so we're not the old NHS England. We've got Health Education England. We've got NHS Digital, which is the section that would have been, which has come into my part of the organisation. And so we run services of our own, big national digital services, as well as investment programmes, as well as supporting people to deliver better patient care. And so we as an organisation are committed to doing it, and we have are developing a programme of work with AMARS and others help actually to change ourselves. The third bit is, I think, it is important that we have conversations actually and set expectations. We're a public service, and the public quite rightly have expectations of us. We need to listen and learn from them as to what matters to them, but also our democratic elected government has also got things that the public have a right to expect of us. And so it's entirely right, I think, for us to hold ourselves to account for those things. But that doesn't just mean having what people would call old school performance management conversations. You know, your performance isn't good and you need to sort yourself out. Go and do these things. We've got to have performance improvement conversations. And as Amar says, that does mean shifting from a culture where you're telling people what to do to a culture in which you're actually framing the problem and then giving people the space, the time and the tools in order to do that. And I know that is something that we're very committed to and that Amanda's very committed to doing as well.
Brilliant. So, Amar said improvement is a science. We're now going to move to a highly scientific approach to the last 12 minutes of our session. I'm going to ask a question. I'm going to give the panel no more than 30 seconds to answer my question. I'm then going to take 5 points around the room, and none of them must last more than 30 seconds. I'm then going to bring our panel back, and they'll have 1 minute each to pick from the points and the questions that you've put and to say something to close. It's going to be unbelievably like this over the next few minutes, folks. Are you ready? Are you in the kind of mood to kind of accelerate things? Okay, so here's my question. You've got very little time to answer. It's my obsession. I think one of the weirdest things about the health service is how little time people spend in each other's organisations. And I would say about innovation, something I've come to understand, you can read all the innovation guides in the world, you can watch all the innovation videos in the world, all the best practice. It's only when you actually go somewhere and you look at it and you feel it and you talk to the people who've done it, who will normally say to you, oh, we got it all wrong initially and we were quite lucky when, and I wouldn't do it like this, by the way. And then you get it. But, you know, leaders don't really spend much time, and clinicians don't actually spend that much time. So what can we do to encourage people to be more open to learning from each other? Amar, 30 seconds, go.
Well, first we need to figure out where the best practice is, and that involves being able to curate stories and tell stories in a really open, transparent way. Secondly, we've got to think what are the big questions we want to learn about in the true origins of benchmarking. Now we've sort of changed that word to mean comparative judgment, but actually the origins of that were figure out a question, go and figure out who's best in the world at that, and go and learn in a really systematic process. And that needs some leadership support because we need to see almost continuous improvement as being analogous to continuous learning. If we're not learning as we're improving, we're not really improving. Brilliant. Sarah?
I mean, for me, it's about those intrinsic motivations first, like why are we all here, really, to deliver the best care for patients. I think for me, it's around the skill set and bringing improvement into like the everyday, the ability to listen to other people, the ability to be brave, the ability to flex bureaucracy within organisations, and I guess in terms of that system thinking to step into the gaps between organisations. It's quite exciting, really. It's kind of working outside the lines a little bit in a way that can really drive change. So, yeah, that intrinsic motivator would be the thing I'd emphasise.
So, Sam, one of the great things you've got, because it's a really big system, you know, there's real scope for leaders to. How do you get people not to be threatened by other people's brilliance, but to want to kind of go in it, understand it, repurpose it for themselves?
Well, we're really lucky. We've got a great provider collaborative. Our 11 NHS organisations work closely together, and they're actively working on peer review approaches. So they're doing it. I think the other thing I would say is sometimes people can give the illusion of greatness. Sometimes people can, it can sound good, and but actually it may not be good. And I think there's something for me about how we build the trust and psychological safety to not only go and look at what's good, but support people where they've got problems and difficulties. And I think actually radical candor and openness about where we've got our challenges would help us kind of accelerate our improvement much, much quicker because of the skill set that lies across all of our systems. So if we can drive transparency and openness alongside peer-to-peer learning, we'll make quicker progress.
And then at the national level, quite often there is a kind of, even though we've got rid of elements of the internal market, it does feel quite competitive, who's at different levels of various frameworks, who's doing well, who's not doing well. Then the bloody HSJ comes along and reinforces that by kind of having heroes and villains in this way they report things. I love the HSJ, by the way. I'm just saying that out of fear. How do you kind of reconcile that kind of sense that we're all being compared with each other with creating a culture where we want to learn from each other?
So the first thing to say is that the whole approach to, for example, tiering organisations is not pejorative. It's an approach by which actually you can give a disproportionate amount of focus to those people who are asking for the most help, and that is fundamentally the purpose of it. It doesn't feel like it because nobody wants to be in the area where, nobody wants to be in an organisation where you said, "Hi, I'm NHS England, I'm here to help you." So you've got to be, I think, clear, and you've got to set a tone and a purpose as to what the point of that is. That's the first thing. The second bit about being real, if you like, is I think as a leader, my experience is you have to carve out the time to do it. When I was working as a clinician and as a senior director, every Friday was my all-day clinic back in Birmingham. No one could contact me. I couldn't do any meetings. That was just it. I was focused on patients. What I do now is those Fridays now I spend going and visiting providers and systems and places and so on. The third thing I think about as a leader is about organising the way and being clear about how you want to spend your time and working with the local system or the local provider to do that. When I go to places, one of the early things I learned was people were desperate to sit me in a room and give me a load of PowerPoint presentations to see all the amazing things you've done. Nowadays, and what I've learned, and I've learned this from other leaders, is you say, right, I'm coming for 5 hours or 6 hours or whatever it is. We'll have a third of the time where you can tell me all the things that you want to tell me, both the good and the bad. Tell me the things that you're really proud of, the things that you're finding really challenging, and the things that are really difficult. The second bit is I want to talk to staff. So give me time on my own without senior leaders there, just listening and learning from staff and listening and learning from patients. And the third bit is actually let me spend time actually in clinical areas, following staff around. With me, it'd be doing a ward round, sitting in a surgery, going into an operating theatre and so on, actually see it and live it and experience. And I think that carve out and being very intentional about it is a really important role for us as leaders.
Finn, that's great. Okay, so we've got 6 minutes to do something amazing. I'm going to wait for you to put your hands up. I really do care where you come from, but I don't want you to tell us where you come from. It's going to be completely egalitarian. I just want your name. I don't care if you're important or not important, whatever. Just make your point, and you'll have 30 seconds and no more. 30 seconds, you're going to lead us by being short. And then, panel, you just pick one of these points that you want to respond to in your closing comments. Okay, here we go. Quick fire. Go.
Hi, good afternoon. Thank you. Just quickly, in carving out space, how is the financial model and the way the regulators work going to allow us to actually have the time and space to deliver, whilst recognizing that their role of a yearly review can actually benefit but sometimes hamper that move to a more long-term thinking rather than a short-term quick reactive working? Thank you.
Great question. Right, who's next? Yeah, here. Great running, by the way.
Hi, I'm Sandra. I just want to know how we can cut the bureaucracy in the way that we did during COVID, and we did some really innovative stuff and it was brilliant. It seems to be going backwards and everything's taking forever now.
Brilliant. So how do we get the culture of COVID back? How do we reconcile short-term kind of performance frameworks with longer-term change? And there's two arms here. Yes, there's one here. And then there's someone just behind you. Right, go.
Oh, hello. My name is Mina. I'm not going to tell you where I'm from, but I'm a clinician in background and now office-based. So I think even though I have a lot of lived experience with health inequalities and also try to bring the voice of clinicians and frontline workers to the table of decision making at a strategic level, I feel still I might lose that connection. And I think the main question for me is why can't we remove barriers across the NHS, for example, and organizations where people can physically go and sit in each other's office space, or office space people with strategic roles to go and sit in acute trust, I don't know, somewhere on the board, GP practices, work from there, work on policies and strategies there to keep that connection and keep connected to the real world, basically. Why can't we remove barriers? Because at the moment we can't just go off and work from anywhere we want. But I think that's a very important way of keeping connected and not to be out of touch with realities in the NHS.
And then about 4 rows behind you, there's somebody else, yep. And then we're going to have Lady in Red again.
Hi. How can and should industry help with continuous improvement?
Oh, I love that. 8-second question. You might even get 2 more now. Lady in Red.
Thank you. I'm going to be deliberately provocative. Continuous improvement is fabulous. How do we make sure we're not continuously improving the wrong things? And when do we need to be brave and do transformation rather than just continuous improvement?
Brilliant. Awesome. Is there a last? Yeah, right there in the middle of the row. You've been brilliant sticking to your 30 seconds, by the way. Thank you. Yes.
How can we use governance and audit in service of continuous improvement?
Oh, these are brilliant questions. Oh, fantastic. Right, panel. Just think for a moment. You're going to have to choose one of those. They're all brilliant, but you're going to choose one that you want to respond to. And we're going to go in the order we started with. So, Vin, pick just... I know you want to do all of them. I know you do, but you're only going to have one.
So I'm going to do doing the wrong things. Firstly, I think you talked at the beginning, Matthew, about split screen thinking. We have got to carve out time not just to do the day-to-day, to look forward. So we know, for example, and it's great news that we have, we're all of us growing older and will live for longer, and that means that we will have more and more long-term conditions as we get older. That is the biggest driver of increased demand upon health systems worldwide. That's the biggest driver. The number of people with more than 3 long-term conditions has trebled in a decade. So we know that in order to deliver the kind of services and to support our populations, we've got some big shifts we need to do. Prevention, moving to population health, moving to place-based care, parity of esteem, not just of physical and mental health, but the social determinants of health, life course approaches from pregnancy to palliation, but as well as being a more productive health system and being a personalised health system that really meets the needs of people. If we are going to be able to create a new system that's like that, that's genuinely integrated and personalised and enabled by digital technologies and delivering the kind of fantastic advances in healthcare at one end of the health spectrum, if you're really unwell, but really fantastic integrated care at the other end of the care, we've got to have that one eye on the future and say, these are the care shifts that we need to be able to shift to. And so what we've got to do is look at everything that we are supporting staff and patients to improve locally, but have that eye on the future horizon and say, how does that? So I'm not just improving my outpatient processes, I'm also saying, how am I going to deliver a completely different model of care to support the children I look after with increasing numbers of long-term conditions, because children that, sadly would have died when I was a young junior doctor are now thankfully surviving into adulthood.
Brilliant. Sam.
I just want to touch on new power, old power, mind shift in terms of leadership styles and little changes, big changes, so the sort of the transformation piece. So let's not underestimate the power of small change. And actually, the reality is it probably will be lots of small incremental changes that delivers the big shift and the big change and the transformation. So we sort of have to attend to both. It's not a sort of a binary one or the other. I think we're at a big pivot point in society in terms of power. So from a leadership perspective, whilst structure and governance is crucial, is important, we need to move away from hierarchical based health systems, and we need to understand and accept and foster the reality that power sits and rests in our communities, and we are public servants in service to our communities. That is quite a big mindset shift and practice shift from a leadership perspective. I'm not perfect at it. We're not perfect at it in our system, but we're working on that. And we're going to have to support each other as a leadership community as we transition on that journey too. But ultimately, we want to get to that point, not where the chief executive's the boss, but every single one of our population feels in control of their own health and well-being. And we've got all of the enabling structures, conditions and environments that fosters and supports that.
Thank you, Sam. Sarah.
I'm going to go with the question from the second row around bureaucracy and go into quite a very practical point here, which is that we talk about partnering with people, communities, voluntary sector organisations. Lots of the organisations that National Voices works with and within our membership are like tiny micro-organisations who have access to the communities that are not being heard within health and care services, who are least well served. And so many of the time, just the practicalities of actually getting money across the line, so those organisations can actually engage communities, bring them in a different way. Like the bureaucracy, the huge contracts, the time frame where you're working under risk as an organisation. The values and principles of being equal partners are there, but the processes let it down. So there's something for me around bureaucracy. How do you create the space, create the infrastructure for people who are leading the way on co-production with communities to really get on with the work and not be held back? And that permissiveness, I think, baked into the kind of bureaucratic structures. Hyper practical.
Thank you, Sarah. Amar.
So if we think that a continuous improvement culture is just about improvement, we need to think again. And it might sound a bit heretical coming from me, but actually improvement is not sufficient. And actually what we mean by a management system is that we need improvement used on the right things in a really rigorous way, but also aligned to really good planning and redesign, which I think is what we mean by the word transformation sometimes. Aligned to really good daily management, which is quality control, which will actually solve today's problems if we had really good quality control. And then use assurance judiciously to really check that we are, where we should be, and be able to demonstrate that to our constituents. And the balance of all of those four components is what a really good management system is that underpins a continuous improvement culture.
Brilliant. Well, look, you've been a fantastic audience. It's been a fantastic session. It's only overrun by 2 minutes, so I'm going to get an improvement gold star from the organisers of the event. It just remains for me to ask you to thank our wonderful panel. Thank you.